Right, thank you very much, Julia, and good morning. It's really great to be here. So I'm sorry I've caused chaos with your agenda. Thank you. So this is a big title, and there's a bit of scene setting to do before talking about things that have recently come in and things that are yet to come in. So I'm going to do it's going to be a 20 to 25 minute whip through of where we are and perhaps where we're going. These are my conflicts. So in psoriasis treatment, it's been an amazing time. Over the last 20 years, we've moved from having a ward full of psoriasis patients receiving topical treatment to rarely having any inpatients in our hospital wards with severe psoriasis. And that's largely because the treatments have evolved. And we now have such choice that it brings with it a responsibility to choose the right treatment for the right patient at the right time. And having more treatments that work in different ways to suit different patients is helping us. So the aim of this talk is I'll try and give a bit of an overview of where we are in the landscape at the moment and some of the recent additions. I will focus on biologics. I'll focus on some of the newer oral options, which is becoming an area of great interest again in psoriasis. We've moved from tablets originally through injections, and now in the world of industry and pharmaceutical development, oral medicines are a real focus again. And there have been some developments in topical treatments, although they haven't rippled through to the UK. So I will touch on that briefly. When I was thinking about this talk and what to focus on, there are many areas that could have been dived into, but I suppose these are three that I might think about with you. So we've got different forms of treatments and more of them coming through. We've increasingly got new and different disease targets, so the drugs are working in different ways. And we're having treatments coming through for different forms of psoriasis. So you've just heard about generalized pustular psoriasis, which I think it's fair to say has been very, very challenging to treat for a long time. There hasn't been the same innovation in that context. And we've often used treatments that have been used for plaque psoriasis in pustular psoriasis, but they're not quite as effective. And there has recently been some great development in the world of pustular psoriasis. So we'll touch on that. So we have broadly topical treatments, phototherapy, which is UV light-based treatment, oral tablet treatments, and injection-based treatments or biologics. And I'm going to focus a little bit more on that end of the spectrum today. So this is how treatments have evolved over time. And you can see there has been a slow and steady evolution since the 1960s, some drugs that you're all familiar with. The biologics, of course, hit the scene in the early 2000s. New oral medicines coming through later through 2010s into 2020. And, of course, ongoing innovation in that field at the moment. So let's first look at biologics. And to start, just to explain how they work, I'm just going to go back to very basics on psoriasis. So if we think about the immune system and what goes wrong in psoriasis, there are two white blood cell types that are particularly important. And in the immune system, there are these little signals that can interact with these white cells to promote inflammation. And we know in psoriasis there are two important cells. One's called Th1, one's called Th17. And these signals, which are called interleukin 12 and interleukin 23, activate those cells and cause them to produce more pro-inflammatory signals, one of which is called tumor necrosis factor alpha, TNF-alpha, one of which is called interleukin 17. And it's those two, and it's much more complicated than this, but these are two of the core pathways that are involved in this disease that result in the development and the inflammation that we see as psoriasis. So biologics have evolved to target tumor necrosis factor alpha. That was the first set of biologics that came along. Interleukin 23 and interleukin 17. And it's amazing that we now have a lot of different biologics. Oh, apologies, that's gone off the bottom. But there are 12. You'll have to believe me because they've dropped off. That's a little unfair to the IL-17 group, I think. But there are TNF inhibitors, IL-23 inhibitors, and IL-17 inhibitors. And the dosing varies, which is fantastic because, of course, we have ones that you take every week or even twice a week, all the way through to ones that you take every 3 months. So more options, practically different in the way that we take them, but how effective are they? And we see paper after paper emerging in the last 5 to 10 years about this, and keeping up with it is not an easy job. But what I've tried to do is to distill it into a figure. And I want to say there are some very clear limitations to this. I have simply looked at the late phase trials for these drugs, and I've pulled out the data on them. This is not direct head-to-head comparative data. This is literally taking individual data sets from the late phase trials to get some idea of the trend with these drugs as they've emerged over time. And the main message is here we're looking at the percentage of patients getting 75% improvement in their objective disease severity. And if we start with methotrexate, which is based on an oral publication, 15 milligrams a week, you can see around 40% of patients achieve that. And as we've evolved through the biologics, so we've got the three letters at the bottom, but it's adalimumab, ustekinumab, secukinumab, ixekizumab, brodalumab, gozalkimab, risankizumab, and bimekizumab. You can see that the basic trend is that we are slowly getting higher and higher percentages of patients up to that 75% improvement in disease severity. But we're not actually aiming for that anymore. You and we want better than that. So we've now moved into an era of clear or nearly clear. That should be our aim and our ambition of treatment. And what we've seen as more and more drugs have moved through is almost this Dave Brailsford marginal gains picture, where we're not looking at EASI 75, we're now pushing the EASI 90s up and the PASI 90s up and the PASI 100, so the 90% improvement and the 100% improvement. And so if we now look at the differences with those, so on the white bars you see the 90% improvement with these drugs. And please don't look too much at the individual drugs, it's more the trend I'm trying to pick out here, because as I say, there are limitations with looking at data like this. But you also see that, so PASI 90 is up towards 80, almost 90%, and PASI 100, so clearance of psoriasis, reaching up to 60 or just over 60%, certainly by the 1 year point. And there have been some very robust data sets put together looking at this and trying to piece together all of this data from the different trials to put it into figures that we can digest to look at the effectiveness of all of them. And they do that in part through what are called network meta-analyses. So they take data from individual trials and they try to form indirect comparisons to give an idea of how good a drug is and how well tolerated it is. And there are big limitations to this because, of course, every trial that's done has a different population of patients. So there are different inclusion criteria and exclusion criteria. They have different endpoint times, so some read out at 12 weeks, some might read out at 16 weeks. And so you can only ever take this with a pinch of salt, but it does give an idea. And what this figure is showing is the further along the x-axis you are, so the axis at the bottom, the more effective the drug is based on being able to get patients to that clear or almost clear level. And the higher up the graph you are, the better tolerated the medicine is based on serious adverse events. And if I was to tweak just one of those things and look at niggles rather than serious adverse events, it would change this figure. So it's important, again, just to bear in mind the limitations. But what it shows is you have some broad groups of treatments. So risankizumab, bimekizumab, if you're in the top right, very effective treatments, well-tolerated treatments. Another group here in the middle right, so very effective treatments, well-tolerated generally. And then in the group in the middle, so reasonably effective and reasonably well tolerated. So you can see clumping of different treatments. It gives us some idea of how they might compare. And we've learnt many things over the years about biologics and broadly through bad beer. This is data from bad beer, which has been really one of the greatest successes, I think, in UK research, collaborative research, because so many sites have taken part in it. And the one thing that we know about biologics is their effect doesn't always last. And you can look at what's called drug survival, so the likelihood that patients will remain on the drug over time. And that's actually reflective of many things. It's not just reflective of how good a drug is or whether it works or doesn't work. It's also reflective of how well tolerated it is and what else is available. So again, you have to take this data in the way that you can with the limitations of it. But one thing that has come through is that it looks like certain drugs and certain classes of drugs survive slightly better. So the percentage of patients, for example, to understand this graph, the percentage of patients on adalimumab after 2 years of treatment reduces by about 25%. So you've got about a quarter of patients come off the medicine over a 2-year period versus, you can see here at the top, gozalkimab, an IL-23 targeting drug, the percentage is nearer 10%, just under 10% come off the drug. And a huge amount of data has come out of bad beer, but some of it has looked at what factors influence how likely a biologic is to be effective. And these are some of the factors that came out in one publication that were negative predictors, so ones that predicted slightly worse outcomes: female unemployed, smoking, increased weight, palmar-plantar involvement, and small plaque disease as examples. So it's a quick whip through of biologics and how they've evolved in terms of effectiveness, but how safe are they? This is another thing that bad beer has been instrumental at providing data on. I'm going to summarize this in one slide, which is obviously a gross simplification of this scene, but they all carry an infection risk, and that infection risk seems to be similar to the standard immunomodulators that have been used for some time based on previous publications. And the different groups of biologics carry their own specific side effect profiles, but generally they are all well tolerated. So TNF inhibitors, you do have to be careful that people don't have tuberculosis before they start, because that part of that immune system is very important for defending us against TB. And they can very rarely cause a bit of inflammation of the lining of the nerves and worsen existing heart failure. The IL-17 group can slightly worsen your risk of fungal infections, so candidal infections as one example, because interleukin-17 is important in our fungal defense. They can slightly increase or exacerbate inflammatory bowel disease, and occasionally we're seeing them causing an eczema in people with psoriasis. The psoriasis goes and you can develop an eczema occasionally. The IL-23 group of drugs seems to be very well tolerated aside from that infection signal, but of course they're more recent and we need to monitor that over time. So I'm going to draw close to the biologics part and focus a bit on new oral therapies. And I can't go through all of them, but I'm going to focus initially on two that have more novel mechanisms of action compared to the oral drugs of the past. So apremilast, or Otezla, is one tablet that's now been around for some time. It's a twice-daily tablet, and that works in a slightly broader way than the very targeted biologic treatments, but it works in similar ways. So it works by reducing inflammatory signals such as interleukin-23 and tumor necrosis factor, and increasing anti-inflammatory signals. And then deucravacitinib, or Sotyktu, which is a much more recent treatment that's been introduced, is a once-daily tablet, and that works by reducing interleukin-12 and 23 as one of its main mechanisms. So how do they compare? Again, this is my own indirectly created figure to give you some idea of how they stack up. This is the 75% improvement level with these drugs. So apremilast gets around 33% of patients to 75% improvement. Deucravacitinib gets over half of patients to that level by 16 weeks. But it's important to say that oral medicines can sometimes take a bit longer. And we know that deucravacitinib, for example, got nearly 60% to that level by 24 weeks. So just another caution there in interpretation. So not quite to the high levels that the biologics had achieved. And where do they sit on this network meta-analysis from the Cochrane group? Well, they sit in the middle. So deucravacitinib is in the same ballpark as adalimumab and ustekinumab when you look at effectiveness based on these measures. Their safety profiles, though, are a bit different. And as we're getting these new treatments coming through with new mechanisms of action, the one thing we have to be mindful of is how well tolerated they are. And with apremilast, the key things I wanted to point out are it can cause a bit of stomach upset in some patients. It tends to get better over time. It can cause headaches. And there has been an NHR warning around, and this is rare, it's important to say, but low mood and suicidal behaviour, and some very important advice given by the MHRA about how we as clinicians should look out for that and how patients should be made aware of that and monitor it. And deucravacitinib has a different set of side effects. It works in a different way, as I said. It's broadly well tolerated, but infection with a very slight increased risk of herpes simplex infection, and it can cause acne and a folliculitis type picture in some people. So a slightly different set of side effects. So what else is coming down the track? Well, there's still an awful lot of excitement and work going on in psoriasis, and I haven't got time to focus on all of it, but there is one new oral treatment that's very exciting because it's the first oral treatment that's specifically targeting one cytokine, and it's called icotrokinra, and it blocks interleukin-23 function, so it blocks this part of the path. And you can see in the box on the right a once daily tablet. It is proving very effective. It's now published its phase 2 and its phase 3 results, and it's getting nearly 2/3 of patients to that 90% improvement level, and it's getting 40% completely clear of psoriasis. And the important thing, and I'm going to touch the wood on this lectern, is that so far it has been very well tolerated, just as the biologics have that have targeted IL-23. So where does that come into this overall figure? Well, I think it is going to raise the bar of oral treatments and tablet treatments, and it will further this conversation about tablet or injection again, and increase options for you as patients, importantly. I mentioned at the start there has been some development in topical therapies, and I want to start by saying, unfortunately, these haven't reached our shores yet, and I'm not sure they're going to. So part of the reason why I didn't want to put too many slides in about this is that we can't easily use them. But to let you know, this is one called tapinarof. This works in a totally different way. It works on something called the aryl hydrocarbon receptor. It activates that, which then reduces pro-inflammatory signals, including signals like interleukin-17. And it was used in groups of patients who had mild to moderate disease or localized disease, and it did have reasonable effect. It got about 1/3 of patients clear or almost clear after 12 weeks when they started with at least moderate disease severity. Pretty well tolerated, had a few niggles with irritation, contact dermatitis and itch in a few patients, but generally well tolerated. Before I move on from topicals, there are other topicals. There's another topical called roflumilast, which is almost a topical form of apremilast, a tablet I mentioned, which is also proven to be effective. It has a pretty similar effect profile, actually, to tapinarof. Again, it's licensed in the US. Neither of these are licensed in the UK or Europe at the moment. Now, I'm going to end with a very exciting part here, because pustular psoriasis has been a big focus of research at Guy's and St Thomas's for a long time, and Jonathan Parker and Catherine Smith and the team had done a huge amount of work on this. And back in 2010, 2012, a group of patients were identified that kindly contributed to research in the genetics of this condition. And a gene was found that was related to part of the immune system that affects something called interleukin-36 signaling. This is a very inflammatory signal in the immune system. It was a really exciting finding. It was found at a similar time to a group in Paris found the same thing. And what's happened since is remarkable, because genetic discoveries don't always result in new treatments. This is a remarkable story. But this has, because drug companies started working on this IL-36 signal and how you can potentially block it. And one antibody treatment, biologic treatment that's come through is spesolimab from Boehringer, which specifically targets interleukin-36 signaling. And what's remarkable is the trials that were run in generalized pustular psoriasis revealed really significant early results. So patients that were given one dose, and some needed a second dose a week later, almost all of them were clear or almost clear by the 4-week stage. And you can see one example here across the bottom. And this drug has been going through NICE recently. Many stakeholders have been involved in getting a positive outcome for this drug, and it's very, very exciting in a field where we've had such limited options. So to finish, I've spoken about lots of treatments, many coming. How do we choose the right treatment? How do you choose the right treatment? And these are just some of the things that are brought into consideration. So it's the type of psoriasis that you have. It's practical things around tablets. Now we're going to have more tablet options coming through. Frequency of taking the things, the storage, if you're traveling a lot, work, life habits. Other medical problems are key. So some medical problems mean that we would avoid certain classes of drugs. Some mean that we might actually use them. So increasingly, we've got drugs coming through that work in multiple conditions. So they treat psoriasis and other things, whether that's arthritis associated or inflammatory bowel disease. Previous experience and treatment history is critical. So if you've responded to one drug in one group, it's likely that you'll respond to another one in that group. So it may change treatment decision at that stage. Current status, are you in a flare? Are you very unstable? Do you need a treatment that works very fast? Or actually, have you got chronic stable disease in which we have a little bit more time to get control? And then things like body weight and physical features. So these are just some of the things that come into the decision. And the decision is very much a partnership. It's the clinical team counselling patients, and both making a sensible decision based on the information and the history. So to summarise, we have really an amazing evolving landscape still, increasing number of treatments, 12 biologic options, increasing oral options, and they all have their strengths and weaknesses. And as I say, I think the challenge right now for us is a nice challenge, because in lots of areas of dermatology, we don't feel like we're in a sweet shop with treatments. But now, we do have this wonderful array of treatments, and the responsibility is now choosing the right one at the right time. So I'm going to stop there. Thank you.